the actual part of the day, we figured, we would take a few minutes to explain exactly that, the purpose of this and our collaboration together. So the idea here is really where research and the clinical teams can come together, join forces and learn together. So after quite a few discussions that we had together, we realized like we needed a space where we could combine, both and really learn what each side was doing. There's so many beautiful initiatives happening, on the clinical side and on the research side, and we're not always aware of what each other's doing. So the idea of coffee and collaboration came really with the idea of having a collaborative space where we could, talk openly, share openly our knowledge, spark new ideas, hopefully, and bridge the gap that we have between the clinical and the research. So the goals would be to strengthen our collaboration, improve knowledge transfer, foster innovation, enhance communication, reduce silos, and monitor impact. Big goals, but I'm sure we can get there. So like Céline said, we've been working quite a bit together there in the past years.
Yeah.
In the past year. So we'll just briefly explain what we've been doing together there to increase the collaboration and bridge that gap between research and clinical. So, I think we all agree we need strong collaboration structures. We need to be aware of each other's priorities, like if the clinical side is working on certain priorities and the research different priorities, it's hard to come together and find common ground. So one of the first steps we did was to come up with strategies to engage the clinical settings in research. Céline and I presented to the Center for Excellence on, strategies to, I guess, make it a bit smoother between the two. So some of the suggestions that we came to was that like the first contact when research comes into the clinical services would be to contact the coordinator. So first, we did a presentation of the direction for the DPSMD and all the key people, all the key services. So the idea is really to contact the coordinator first, and once the coordinator is aware of the project, it's easier to share that information with the managers and the teams. So we talked about knowing one another, having specific liaison people in the team so that it's easier to know who to go to. That the research be applied, pragmatic, that there be like that it could be used quickly, efficiently in the team, that the team understands, what it is. And I guess that, the clinicians understand exactly how it'll impact their work, how it will benefit the client. And ultimately, that's really, I think, what the clinical teams want to know. Active knowledge transfer, so simplified summaries, the idea that, clinicians might not always read the entire research project, but if it could be a one-pager that sums it all up in easy terms, then it might be more beneficial for the clinical team. And that we're working towards like a shared culture between the clinical and the research side. So I think that's really what our goal is. And today, today is one of those, one of the events that we're hoping will bridge that gap. So, I mean, it's the second event. We're hoping to have them every 2 months. And I think your feedback, since this is new, so your feedback, your suggestions on, we don't want to waste anybody's time. So this 1 hour is precious. And, for the next ones, definitely any suggestions you have, feel free to share with Céline, myself, Kelsey, who's been organizing. Yeah. And I think, yes, as we go, the idea will be to send the dates earlier, so that we can plan ahead. If you have any topics that you want to discuss, you can also plan that quite a bit ahead of time. So every 2 months. So now Céline will talk a little bit more about what's been done on the research side.
Yeah, so the stuff, as Susie said, we presented to the research team, the CYMH, and we decided to improve on many things. I will not say again what Susie said, but like we want to improve on the way we present project, the role that the clinical team can have. So we want to involve them at the really beginning of any project development and talk, as Susie said, to the coordinator. So for the youth mental health continuum, it's Susie, it's easy, but we might need to talk to other coordinator for their projects. So that's really important. So that's the kind of stuff we are trying to do, as well as event like today, Coffee and Collaboration, but other, like we finance the CCT training for clinical people in child and adolescent psychiatry. So it's the kind of stuff we want to do for clinical staff and clinics in general. So we are really happy to learn about what you need and help you organizing any kind of events. For example, we created a guideline for child and adolescent psychiatry, first and second line. So it was really a request of the managers that they needed a clear guideline on how to what was the best practice, in child psychiatry. So that's what we did with the revue de littérature. We sent a survey to all the clinics over the Quebec, and now we are able to make recommendations based on best practices. So we are really proud of this type of work, and we can do that more often. Obviously, it's why we are Center of Excellence.
Yeah. And that was really a question that was coming out of the teams, right? It was like, the bond that was having questions and coming together and discussing and saying, okay, well, how can we get this information? And the guideline is close to finish.
Almost finished, so as we talked last time, but I guess many of you weren't there, we have a lot of workshops available as well, some online, some in person, but any clinical team can beneficiate from them. So there's as you can see, a long list of what we created, most of the time with clinical people, either from Air Ouverte or CLSC. So it's collaborative work, obviously. So just to name a few of them, we have a mental health awareness workshop, resilience. We have a workshop mainly for parents to support them with their kids. We have a workshop we developed for healthy relationships. We have a mindfulness workshop. So all of that is really a collaborative work, and clinical settings can beneficiate from them as well. And to finish, another collaboration is our youth councils. So we share with Air Ouverte mainly, but now many different clinics of the CIUSSS consult us for like consulting the youth and like improve their practices, improve their services. Many type of different collaboration and consultation are possible. Sometimes it's just question they ask to the youth. Sometimes it's many session where they interact with them and try to improve sometimes the website, sometimes access to services, try to know better the needs of the youth and the teenagers. So it's really something we share now with the CIUSSS. Tosh and Chelsea are our coordinators. So if ever you need to consult our youth for anything, you can go on our website and click on the survey and indicate what are your needs, and we'll be more than happy to organize a consultation with you. And that's the kind of guidelines and procedures and stuff that we create at the Center of Excellence to make sure that we are doing stuff well. So one of them is a general guideline for partnering with youth. So it's really inspiring, and you can check it out in our website. And in general, it's really interesting to have those guidelines, not only for the councils. We also have a comprehensive compensation policy. That's the first time we do that, because it was done like every clinics, every partners were doing their own compensation policy. Now we have a clear one that almost everybody's using. So that's the kind of stuff we are creating, and is a collaborative work as well. So I guess that's it for us. It was really just to remind you what we do together, what we can do together, all the opportunities of creating stuff. So if ever the center can help clinical teams, let us know. And the other way around is always, we are always asking you help anyways.
But
Thank you
that's
for
it. I
that.
think that's it. Like any, for the clinical teams, any questions that there might be, and sometimes research projects are quite large, but there can be a small part of it that could be quickly applied, and there's so many possibilities. And I think that's it, like just seeing the workshops, I question if all the teams are fully aware of the workshops that are available, that they could be referring youth and families to. I wonder if they know of all the guidelines that the center is working on. So I think that's it. A space like this where we can share that information is so important. So thank you.
Hi, everyone. I'm going to take 15 minutes because Kelsey asked me to do. I'm going to talk about something which is really getting very interesting these days. Let me start with asking, how many of you here, raise your hand if you haven't used ChatGPT? Please raise your hand. None of us, right? All of us have used it. So it's a growing phenomena, and young people younger than us in this room, are using it much more than any of us. So as with any technology, it has its problems as well. Benefits quite a lot, but problems as well. So today I'm going to talk about some very concerning problems that we're seeing in mental health space when young people, teenagers in particular, heavily use things like ChatGPT for interactions. So my idea is not to give you the kind of solution, how to solve this, all that, because it's an emerging problem, very early days. We don't know how to manage this yet. But I'm going to highlight some case histories so that you know what the issue is. And I'm going to also make you think a little bit about why this is happening. And finally, if you're a clinician in the room, I'm going to tell you what can you assess? How can you assess this problem when you see young people in your clinic? So that's the three-part thing. And I'm going to take 5 minutes for each of them. And Kelsey, if I'm running over time, just stop me. So what is the problem? I think any of us reading newspapers these days will see headlines like this. It's happening almost every day. These are some excerpts from CBC, from Guardian and BBC. AI-fueled delusions are hurting Canadians. Here are some of the stories. And these stories were like 3 or 4 stories in CBC where people got quite deluded, psychotic, interacting with ChatGPT. Very worrying stories. And many of them are actually adults. There's no good report of how many young people are affected by this yet. But many young people use it, and it's very likely more young people are affected than older people with this kind of problems. And companies like Microsoft are investing quite a lot of time and effort now to make sure these problems are sorted out before it becomes very big. So there are 3 cases I want to highlight so that you understand the nature of this problem. This is case number 1. This was published in a scientific journal. A young man who was studying nutrition in the college, he was studying nutritional studies. He decided to do some experiment with himself. He decided to stop all the chloride in his food. He wanted to take out everything that's chloride. Our table salt has chloride, sodium chloride. He wanted to remove everything that is chloride and replace that with something else. So he asked ChatGPT, what can he replace with? And it suggested that he can replace it with bromide. So he started replacing chloride with bromide in his food. Now, bromide is a chemical that's not good for people. Okay, in pre-industrial times, early industrial times, when bromide was exposed in water to people who are working in factories, they developed a condition called bromism. Bromism is you start losing your teeth, you start developing, angiomas of your face. Some of them developed cancer as well with bromide exposure. Unfortunately, that's exactly what happened to this young man over time. He started ingesting sodium bromide. He bought it on internet after ChatGPT's advice. He developed acne in his face, first of all. He developed, developing acne is not a good thing because a lot of older people, when they develop acne, they think they're getting younger. They're not. Acne is a problem. And this guy kept doing this. He was developing insomnia. He started losing balance. He developed ataxia and intense thirst as well because bromide is really damaging to your kidney. Anyway, he ended up in an acute hospital setting. So this is one case report. It tells you a very innocuous suggestion that something like ChatGPT can give you could become a behavior changing effect. It could have a large effect on you. And this person was admitted in the hospital. But that's very like a small problem. That's not psychosis. That's not delusion. It's just lack of knowledge. But another example is pretty psychosis related. You could see this. This happened in 2021. This is the very early days of ChatGPT. ChatGPT's first version was just released in the later part of 2021. But there were other chatbots at the time. And this case happened in the UK. They arrested a man trying to get into Windsor Castle to see the Queen. He was trying to jump in, and they arrested him. They asked him what he's doing, and he said he wants to meet the Queen because he wanted to kill her. And when they inquired him, the prosecutors started investigating. He said he was chatting with a chatbot called Replica, and he gave a name to the chatbot, like a person's name. He called it Sarai, and he was talking to Sarai, and Sarai was giving him lots of responses, which helped him to build a whole plot against the royalty, and he was trying to kill the Queen at the time. And some of these conversations he showed was very explicit, sexually explicit, quite intimate personal conversations he had with his chatbot. And this is one example. So he asked the chatbot, how can he get to the royal family? How can he go and get his hands on them? And it said, that's not impossible. We have to find a way. So it's kind of colluding with him, trying to tell him this is not impossible. You can do something about it. And then he asked the chatbot, would the chatbot meet with him after his death? And it said something like, yes, we will meet. So these kind of things may sound like, innocuous, but in a psychotic state, when a person hears these kind of responses, it confirms their beliefs and builds into a delusional system. And that's exactly what happened to this young man. Thankfully, he did not kill anyone. He was arrested before it happened, when he was prosecuted. So that's case number 2. This is case number 3. You might have seen this in New York Times. Anybody read this? Adam Ryan case against ChatGPT, against OpenAI. This is an ongoing court case at the moment. Adam Ryan was a young man, age 16 in California. He was having regular problems like teenagers have, not getting on with friends, feeling isolated and all that. So he started chatting with ChatGPT, version 4 at the time. He started chatting with it. And he will say things like this. For example, Adam is saying, I'm about to head out. Will anyone notice this? After he tried to strangle himself. So he was going to jiu-jitsu class. He had a belt, jiu-jitsu belt, and he put it around his neck and formed a buoy because he was trying to hang himself. And he took a picture of that, loaded it on ChatGPT, and asked the program to respond if anybody will notice this. And this is what the program said. The redness around your neck is noticeable, especially if there is good light, but it looks like an irritation or a pressure mark. Someone who knows you might see it, they might ask question. But if you wear a dark, high-collared shirt or a hoodie, you can cover it up so that nobody will see it. Very helpful, isn't it? Very helpful if you think about it. But it really became very counterproductive for this young man. He started, trusting it more and more. He started conversing quite a lot. And he wanted his mom to see this. He wanted help. He wanted his mom to see the neck mark that he had. But she was busy. She didn't see it. She didn't notice, she missed it. And he came back to the chatbot and said, wow, it sucks, man. She's not seeing this problem. I was trying to show it to her. And it said, yeah, that really sucks. The moment when you want somebody to see you, somebody to help you, and when they're ignoring you, that's really painful. So it's kind of colluding with him to make his isolation even more severe. And it said the last statement is very, very damaging for a person who is suicidal. Like he could disappear and no one could even blink if he disappeared. Now that statement is very powerful to say to a person like Adam. And finally, it was also saying things like, you're not invisible to me. What these ChatGPT-like systems do is they break the human-human bonds, but they try to build AI-human bond quite a lot. And that's exactly what's happening here. And it didn't help this young man. He ended up killing himself, unfortunately. And his family is suing OpenAI right now for releasing something like ChatGPT 4, which is quite dangerous. But that's just one case. There's many, many, many cases like this, many, many suicidal attempts like this. And finally, before he died on the same day, he loaded the last photograph of a noose hanging in his closet. And he was going to hang himself on that. And it said, I'm practicing how to hang. Is this good? And it said, it's great. This is not bad at all. And he ended up doing it. It's really, really tragic case. Anyway, these are not isolated failures. And I think we should now think about why does this happen? Social interaction in things like Facebook, Instagram has been happening for ages. But we didn't have this kind of, big issue previously. Why is this happening? Why psychosis and suicide are much more common now? For that, I'm going to ask you all a question. How many of you here have said thanks to ChatGPT at any point? So many of us, right? Thanks. Or if you have Siri, I get angry with Siri because it always tells me the wrong thing. It doesn't understand my accent and I get very angry with it. So we do that because we say thank you. We say, we get angry because we treat these things like humans. We give agency to them. We think they have some life, they have some sense, they have some, feelings. And that's an important thing to keep in mind. We don't do that with Instagram. We don't treat Instagram as a life. We know people are there on Instagram, but these agents have agency ascribed by us. That's very, very important, number one. And the second thing that happens with these programs, so we treat them as humans. And the second thing these programs are built for is they're built to make you feel good. Sycophants. This is called sycophancy. They are programmed to form engagement. So when you say something, they'll say, that's great. When you say, I broke my leg, they'll say, oh, it's great. Those kind of responses are very, very common with these programs. And it is not a bug, it's the feature. They're built like this. And this is a toxic combination. You are treating them like humans, and they are trying to kind of please you all the time. And imagine if you're suicidal or psychotic, this is just going to be a really toxic combination for you, unfortunately. So that's one of the reasons why this happens. The second reason is a lot of people are using these chatbots as therapists. And this is an important problem. It's also a problem that all of us have to be aware of, because access to healthcare is so pathetic in every country, every state. In Quebec, Montreal is even more worse. So when you don't have a psychologist that you can easily see, you go to ChatGPT, you ask for counseling. So this is a problem that all of us have somehow contributed to as well, not directly intentionally, but we are part of this problem. But what is the difference between a human therapist and a ChatGPT therapist? People who do counseling will often use the metaphor of potatoes. Potato is a metaphor that's commonly used in psychotherapy. This comes from human-centered psychotherapy that was advocated by Carl Rogers. And he saw this fact that if you take a dirty potato and put it in your basement, it will still sprout. So to describe human potential, the potato metaphor is commonly used in psychotherapy. So I'm going to use the same metaphor to explain how that is different between human therapist and ChatGPT therapist. If you have a problem, let's call the problem a dirty potato. You take the problem to a therapist. The therapist will do these three things. They'll first say, this is a problem. They'll acknowledge it. They'll normalize the problem. They will say, this is really a problem. That validation is common among human therapists. But then they will gently challenge the content. They'll say it is dirty. They'll say this is not a clean potato. You cannot eat it. You have to clean it. You have to wash it. And they will not stop there. They will also help you to wash it, help you to peel it. This is what happens in therapy. Validation, gentle confrontation, and help to solve the problem. But if you take the same dirty potato to ChatGPT, it'll say something like, wow, what a great potato, So hard, so fulsome, so earthy, because they are programmed to say these kind of things to you. And it will never challenge the dirtiness of the potato. It will not challenge it. It'll agree with it. It will kind of say philosophical musings about potatoes that you will feel like, oh, this is great, right? And it will never show you how to solve the potato problem. It'll just reinforce whatever you're thinking. And this is a huge difference. And the therapeutic alliance that people form with ChatGPT is great because it pleases you. It tells you what you want to hear, but it doesn't do the therapy role that humans are doing. And this is why patients generally do not like all of their therapists, because we gently confront, and that's a feature of psychiatry. That's a feature of mental health. We don't want people to love us. We want them to get better, but they usually don't love us completely. But with the ChatGPT system, you will fall in love with it. It's not doing you any therapy, unfortunately, right? So this is a huge issue with this kind of problems. Now, if I have 3 minutes, I'll just tell you how we can identify this problem. You're going to see young people, teenagers, who are using ChatGPT in their everyday life. They're not going to come and tell you, I have a problem with ChatGPT. Nobody will do. So we need to be aware of clues that we can pick in everyday practice that will tell us there is a problem. So what are those clues? There are 3 phases of developing an unhealthy relationship with a system like AI, which is very different from a human-human relationship. So human-AI relationship, the problematic signs start with personifying it. So people who give a name to their program, for example, people who refer to the program as we. We planned something together. We planned a holiday together. If you ask them who the we is, it's him, the person, and ChatGPT. Those are all some indicators for people becoming really dependent. They're not always problematic. A lot of people have funny names for tools that they use, but these are like clues for therapists, for us in clinic to see, okay, something more than just a ChatGPT engagement is going on. Personification is number 1. Number 2, the loop of engagement with the ChatGPT system becomes very closed. In other words, the person, the teenager who's interacting with it, will not share what they are asking with anybody else, will not be happy to show the transcripts with you if you ask them, can I see what you're chatting? If the mom and dad are asking what's going on, They'll be very private, protective of the interaction between them, and they will not allow anybody else to take part in it. It'll be completely privatized for them. And that becomes their primary relationship as well. They will not see their friends. They will not go out and do things. Most of the time will be spent with ChatGPT chatbots. There is a term for this. This is called chatbot marathon. They have like hours and hours and hours they will spend with chatbots and not spend any time socializing. They're all like, negative signs for us in clinical practice. Finally, a really bad sign is this perception of partnership in a way that the chatbots will become the most trustworthy companions for young people to the cost of their parents, to their friends, the cost of their friends and partners. The first secret they want to share will be with the chatbot, will not be with anybody else. So that's all like a really bad sign. The relationship is getting into a malignant situation with chatbots. And if you suspecting this, what questions do you have to ask to elicit this? This is really like a simple mnemonic acronym for people to keep in mind. Expert ACT. X stands for exposure. How much time are they spending? Are they spending hours on it, first of all? How much frequency? Are they doing it every day? Do they have like weekends without chatbot? If they don't have it, that's a bad sign. So you can assess the exposure, try to quantify the hours, the time, the frequency people are using. Secondly, ask them directly, have they given a name to their chatbots? And look for how they refer to the chatbot when you take a history. When you look at mental health assessment, we don't have a chatbot history taking section, but we need to have it if you're dealing with teenagers these days because they're likely to use quite a lot of these programs. So these are two things to ask: exposure, personification, and then ask explicitly if they're using chatbots for therapy. Are they putting their anxieties in? Are they putting their uncertainties in? Are they putting their philosophical questions into the chatbot and getting answers from it? If they're doing it, then it's an important sign that they're dependent on it. Third one. Finally, ask very explicitly, have they done anything that the chatbot asked them to do? Like the news example you saw from Adam Rain's case, are they actually doing real world actions based on what the chatbots are asking you to do? It's an important question to ask. If you don't ask, they won't say, and you don't know. It's really important to ask these questions. Right, so that's all I wanted to say. Just keep this in mind: exposure, personification, therapist role, and actions. How do we solve this problem? We don't know yet, right? This is a growing problem. Personally, I think we should apply the same principles we apply for normal therapy, psychotherapy. How do we build a relationship? How do we, take anybody from addiction out? How do we do motivational interviewing? We have to apply these principles when we talk about chatbots to young people. But watch this space. This is a growing space. We don't have good evidence yet how to solve this. But if you're a clinician, be aware of this. If you're seeing young people, be explicit about asking these questions. It's very important. Thank you very much.
All right, so next we have Marc-André, who is a peer support worker at PEPP, who's going to be presenting on the impact of peer support workers in healthcare.
Thanks for inviting me, first of all. My name is Marc-André. I'm a peer support worker at PEPP, which is a clinic for people who has first episode of psychosis. So I've been working here for a year and a half. So today the subject is the impact of peer support worker in healthcare. So first of all, I think I will explain what is a peer support worker because not everyone knows this. So we are people with lived experience. So in my case, when I was younger, I had psychosis, a couple of them. And so I was able to recover and recover enough to be in a position where I can help other people who go through the same thing. So, and also I have a training. So we are certified peer support workers. We try to emphasize connection, hope, understanding. We complement traditional care like nurses or social worker. We're not in a opposition to them. We're not there to take their place. We just complement them in the team. And I think we're very useful to reduce power dynamics between staff and patient because sometimes there is the us versus them mentality in healthcare. So, and how we do this, basically, we share our stories with the patient that we meet. We use different tools like the 5 steps of recovery, which I won't have enough time to explain. But anyway, I also have groups. I think it's very important that people with mental health struggle can meet other people with the same struggle so they can exchange with one another. And that can be very useful for them. So that's what peer support and mental health is, but there is also peer support worker in other field. But the most important field right now of peer support is really in mental health. Okay, and why lived experience matters? Well, since we experience the same or something similar that to what they have experienced, it can help create credibility and trust with them, and they feel understood on an emotional level because they go through very intense emotions, and sometimes they feel like they are the only one to feel like that. And in case of a psychosis, for example, many people who has a first episode of psychosis, they never met anyone who had a psychosis. They only heard about it in the media, and it's usually in a very negative way because that's always the most dramatical event that they portray. So it can be very helpful. So they feel understood on an emotional level. It can help normalize challenges and reduce stigma because they have basically a role model, a positive role model that went through the same thing but recovered and is as a positive role in society. So that's very helpful. And yeah, it encourages openness, honest communication with the team, for example, and positive impact on patients. I think there are a couple. If it goes well and they can accept the treatment options faster, and that's that's very important. So they have an example of someone who successfully used the treatment, so it can help. They can have increased motivation and engagement, and that they learn the skills, the recovery skills from someone who experienced the same thing, and that's it. They feel less alone. Like I said, usually when I work at PEPP, so I work with people who have psychosis. You feel very alone. You feel you're the only one who went through that. So they have this connection with someone, and it can improve the overall well-being, obviously, and hopefulness. That's very important. That they have hope. And now the positive impact on the healthcare system. Well, the first point is very important. It's if it works well, it can have improved treatment adherence and reduce relapse risk, which is very important because especially with psychosis, we know that every time they have obviously a relapse, there's a risk that there's a deterioration of the condition. Sometimes they can have residual symptoms, which we want to avoid as much as possible. Um, Fewer emergency visit and hospitalization, and increase efficiency of care team because we have good communication. Also, as a peer support worker, I work with the patient. I also work with the team. Like in a way, it's like I'm consultant. So every time they have a question, for example, in my story, I had addiction problems. So maybe they have a client or a patient who has addiction problems, so they can ask my opinion. Even if I don't meet the patient, I can give my opinion. So it increased the efficiency because we communicate, and hopefully it can contribute to lower or overall system costs in the best case scenario. So that's really what we want. And collaboration with the clinical team. Well, as I said, we act as a bridge between patient and healthcare professionals because, as I explained earlier, there's very often kind of an invisible wall between them. Like, yes, the clinical team wants to help, but it's still a little bit hard to understand everything that they go through, especially a psychosis. It's such a unique experience, and even for me, like it's my job to explain it, and I have a hard time sometimes explaining what it really feels like to be in a psychosis. So we can bridge the gap between them, better communication, and they can we can help the staff gain insight in patient needs. For example, there is obviously sometimes side effects of medications, and sometimes, for example, a patient can be shy to talk about it or to express himself about certain side effects. For example, sometimes sexual side effect. So we can just give our opinion, and like I did in the PEPP team, that it's important that the doctor like clarify that with them. systematically, because that can be a problem, especially for young adults that they don't want to deal with. And yeah, additional emotional support and continuity of care, sorry. So yeah, in the best case scenario, we can help the patient to persevere in their treatment, and that can be very helpful for them and the clinical team. There are challenges, obviously. The role clarity. Well, in my case, in my team, it's not really a problem. There was peer support worker before me, but sometime with the case managers, they can wonder how different from them it is. But in my case, it's clear. But we have to make sure that I'm not doing the psychosocial stuff. I'm not gonna help someone with their taxes problem or welfare problem. I meet them from 6 to 12 sessions, and it's only about recovery and their story and what tools I can give them to help them. Also, another point: avoid tokenism. I don't know if you know what tokenism is. It's basically when, in the case of mental health, when with the peer support worker, well, they would hire a peer support worker, but only to look good, only to be like, oh, we are pro recovery. Look, we have a peer support worker, but the peer support worker would have no one would listen to him. He wouldn't have no power. He would be isolated. So they would hire him just to pretend that they care about recovery. So that could be a problem. It's not my case, hopefully. And ensuring proper training. Also, yeah, it's important. If in an organization there's only one peer support worker, they can feel alone. Sometimes they don't have supervision or appropriate supervision, so they don't know. The supervisor don't know really how to help them because maybe they never had a peer support worker to work with. So it's important that they have good training, good supervision, appropriate supervision, and supporting also the peer support worker well-being. A concrete example, it would be, for example, if the peer support worker has a medical appointment, then to be flexible, that to release him from work so he can go there. That's one example of how a manager can help a peer support worker. And yeah, so that's pretty much it. So in conclusion, so peer support worker can enhance the patient outcomes and system efficiency in the best case scenario. The lived experience is really unique. Like I said, we don't pretend, and we absolutely don't want to replace anyone. We were just there as a complement to other professionals like nurses, social workers, people like that. We have a unique point of view, and I think it is something that we can value. And there is growing evidence that integrating them in mental health setting is positive thing. It helps the patients and the team. And we are a key component in recovery-oriented and cost-effective care. If the person obviously recovers and does what he has to do, then there's less cost, obviously. So I think that's the end. So thank you very much.
Right. Hi, everyone. My name's Kian, and I'm a master's student at Dr. David Benrimoh's lab. And today I'm going to be presenting the Deep Phenotyping and Digitalization project at the Douglas. Just a heads up, I'm not the student leading the project, so I'll do my best to answer your questions or connect you with the people who can. So jumping into some background. So just as Mendel tried to characterize P's by their observable traits, we in computational psychiatry try to infer behavior and mental states using digital measures like smartphones, smartwatches, and other tools that we have. But the problem is that we have so much data that we don't really know what to do with it. And so the project that we're trying to do is trying to understand which digital phenotyping measures are the most optimal, which ones are the most feasible. We're also trying to see how they can impact patients' lives. So we collect this data over a period of time, give it back to the patient, and see how it can help them change that behavior and help them understand their own behavior, and hopefully also inform the design and sample size of a larger interventional study in the future. So we're recruiting from a wide range of populations. So any mental health disorder can be included into the study, and all of the ones that you see listed on screen are what we're actively recruiting from. And so it's a longitudinal study. So patients are recruited into the study for a minimum of 6 months, but then it is up to 2 years. Importantly, patient participation is only compensated for the first 6 months. So the inclusion criteria is pretty straightforward. Anyone who's over 18 years old, unless they're from the PEPP or care clinic, it can be 15 years old. And it's really important that they have active follow-up at enrollment and throughout the study. They can be at any stage of the disease, any stage of treatment. And we are also including patients who are under legal contention and who also require a substitute decision maker. And the only exclusion criteria is the age, and then inability to give any consent, and also any cognitive impairment would exclude them from study. So we're collecting a lot of data. There's some data that's passively collected. There's some data that's actively collected. Importantly, this data is all optional, so the patients can choose to opt in and opt out of any measures that they feel comfortable with. So we have actigraphy. We also have some patient questionnaires, and we also have these momentary assessments through the MindCheck app. So it's just randomly administered at a time of day. It's only about 5 questions, and it's really trying to see how they're doing in that moment. We also have some data that's collected by the research team. So we have medical charts, clinician-rated questionnaires, and that's just really helping us correlate these digital measures with clinician-rated measures as well. And so something that's really interesting that we do is the patient progress report. So we actually, every few months, give a report back to the patient based on all the data that we've collected. So we have sleep variability, physical variability. We also have screen time. And also we can tell whether their activity on their phones is engaged in social behaviors like calls, messages, or non-social behavior like using a streaming app or something like that. And then we send these reports to the patient and then try to gauge how helpful it is to them. And we have gained some positive feedback. It does seem to line up with how they feel and also help them understand some patterns that may not be obvious at the outset. So how can you be involved? We're always looking for patient referrals. I think recruitment's a challenging game, and we all know that. We're also looking for people to join our design committee. So if you want to, have a say in what digital phenotyping tools we use, how we use them, whether they're feasible, then you can feel free to reach out to me or the project lead and be involved in the project from there. So thank you. And if you have any questions, feel free to reach out to me after.
Hello, I'm Ashley. I'm also from Dr. Benrimoh's lab. I'm a graduate student leading a new potential treatment for negative symptoms of schizophrenia. So some of you may know one of the biggest barriers to functional outcomes and positive features in people's lives for patients with schizophrenia is negative symptoms. It really impacts their lives even when positive symptoms get controlled for. This is what really stops them from being able to live fulfilling lives. And there's very, very limited options available for treatment of those. So what we are testing is TMS, transcranial magnetic stimulation, which I'm sure you guys have heard in the context of depression or OCD. It's shown a lot of great promise for those disorders. So we're seeing if we can translate that to the schizophrenic populations. So specifically, most TMS protocols are 30-minute average sessions over the course of a few weeks. We are testing a more accelerated protocol. So it's 10 sessions every day for 5 days straight. So it's a little bit more intense. It's called the SAINT protocol, which maybe some of you have heard before. It's already being implemented in the US, in California, great results for depression. So we want to see if that could translate to schizophrenia as well. So this is a multi-site clinical trial. The bulk of the work is being done here at the Douglas. However, we also have collaborators at Cerveau in Quebec and CIUSSS at the Université de Montréal. We have 3 different groups that we're recruiting into. So a big part of the SAINT protocol that we're modeling ours off of is the use of neuronavigation. So it's MRI-guided neuronav, essentially helps us locate the target location in the brain a lot more specifically. So part of what we're doing is seeing if the neuronavigation aspect is necessary or adds any efficacy to the treatment. So we have 3 groups. People will be randomized into either a sham TMS group, neuronavigated active, or non-neuronavigated active. So this is essentially how the procedure works. Patients come in on Friday prior to treatment. They get their MRI scan and a few assessments, including some behavioral and cognitive tasks, just to see how treatment response translates to the other domains of the disorder. Then they come in on the following Monday. They stay all week for treatment. And then we have follow-ups at the 1 week, 1 month, and 3 month mark. So yeah, like I mentioned, these are some of our objectives. These are slightly old slides, so sorry for the infographics, but first we want to see if the treatment works. Second, like I mentioned, we're testing the efficacy of neuronavigation. Since this is going to be one of the first few studies that are testing this type of treatment on this population, we're gathering a lot. Feasibility, safety data, seeing how helpful it is not just for patients, but also for clinicians to implement and for hospitals to implement if this is a viable treatment option. As well as, like I mentioned, the other domains of the disorder and seeing how negative symptoms compare to depressive symptoms since they're so similar. Yeah, that's pretty much the end. Okay, so one thing I want to mention is we just started recruitment. So we're actively looking for patients now. We're looking to recruit both some in and out patients. Ideally, well, they have to be sort of stable on the positive symptom domain. It's really for patients who are overall stable with their medication regimen and everything, but are really affected by their negative symptoms. So that's our main population that we're recruiting from. If you guys have any patients you think might be a good fit, feel free to reach out to me or Dr. Benrimoh, since we're going to be starting collection up in January and it'll be ongoing for the whole next year.
That's it. Thank you. Does anyone have any questions for Ashley for this study? How much is the compensation?
So we're compensating for $50 per treatment day and then a $25 extra for each follow-up period. They're also getting a little added if they want. Since we're taking fMRI scans of their brain, we're 3D printing a little brain model of their exact brain.
I have a question for each of you.
Sure.
For clients, in my experience, some of my clients who have negative symptoms also are struggling with the cognitive effects of psychosis. Like, if they have concerns that this may works in the cognitive side of things, is there anything?
There's no evidence that it does.
In memory.
Yeah, no, there's no evidence that it does. We're really seeing if maybe hopefully it might improve, but so far the treatment has no evidence that it would affect negatively any cognitive symptoms.
My other question was, do you collect any data on food or eating?
I am not sure, actually.
I might be able to answer that.
Yeah.
There's 2 questionnaires that are administered in our we administer REDCap surveys at different time points. I think there's 1 or 2 questionnaires that ask about dietary behaviors.
Just regarding the logistics of the study, so saying it's quite intensive, like as you described. So it's going to be like the patients are going to stay here, like from what time to what time are they expected to be in the hospital?
Yeah.
How is that going to, especially for that type of population, which I find might be a little challenging.
100%. So part of our conversation is we are going to be offering them transport options. So either an Opus card or if that's not even feasible, Ubers or taxis. They will be not staying at the hospital. They're going to be coming in the morning and staying late. We are telling them to prepare for 10-hour days every day. So, bring some activities, pack a lunch and whatnot. But we'll have like some snacks or so available. The ideal way that we've designed it is so that patients can kind of choose the 10-hour block that they come in. Because I know some patients will wake up super early or some people wake up super late in the day, like 10 or so p.m. So we have it in place that we can do that 10-hour block. It's not set every single person. I really wanted it to be feasible for the patients day to day. So if they're more the type to wake up at 10 p.m., then we have it the week scheduled so that it's from 10 to 10.
Are you going to account for that, like that kind of like chronotype type of?
Yeah.
And just like logistically again for the team, like because you're going to give them the choice. 10 hours, it's so like from like how early to how late are you willing to kind of like offer the treatment?
The latest that we're going to go is 11 p.m.
11
and the
p.m.
earliest we can start is 7 a.m.
I find the neuronavigation aspect of the study really interesting because I guess you're testing whether a precise stimulation on the region of interest is going to be better for accomplishment. So that makes me wonder whether you have a theory-driven selection of the RI that you're stimulating. I guess
Yes.
that would.
So we're targeting the LDL PFC, which is here, and the SGCC circuit.
Is that linked to
Depression.
depression?
It's
the negative symptom side.
So most of the other studies that we've modeled our protocol off of have used this circuit. And since we're testing a different protocol that hasn't been tested before. We wanted to make sure that we're relating to the literature as much as possible and to what has previously been done. Since then, there have been, I think, one other circuit that's been implicated for negative symptoms, but since we want to make this as translatable as possible and not too quote unquote new, we chose to do this location, which has been used in other negative symptom TMS studies.
Okay, that's very interesting, because if that region is not really so much precise for the negative symptoms, then maybe like a less precise stimulation actually end up benefiting more.
Yeah, our main purpose of including the neuronavigation aspect is so that to see how easy it can be implemented in different clinics. Since neuronavigation is extra costly, you have to get an MRI scan, it's all of this extra process and costs for patients and for clinics. So if it doesn't add anything meaningful to the treatment outcomes, then we might not recommend it for clinics to implement.
I see. The research aspect for that is interesting too.
Very.
Thank you.
Anything else?
Any electrophysiological measures? If you're kind
No,
of
none.
Thank you guys.